Thank you so much. Next, we'll be moving on to Greg Rosen from Rhode Island Hospital, Brown University School of Medicine, School of Public Health.
Perfect. Great, thank you so much for the invitation to present, and thank you all for being here. I'm gonna do a little bit of a sharp pivot from hepatitis C and talk about opioid agonist treatment in South Africa, and I'm extremely honored to present our work, which is led by an amazing South African organization called TBHIV Care. We have a contingency of them sitting in the back, on adopting and tailoring methadone services to female sex workers living with HIV in South Africa. The work I'm sharing today emanates from a study led by various academic institutions in the United States and South Africa. I want to begin by extending gratitude and admiration to people who use drugs, without whom our work and much of the work presented at this conference would not be possible. We owe these communities a tremendous amount of respect, recognition, and support. So South Africa has made remarkable achievements in the last decade upscaling opioid agonist treatment, and specifically methadone services. Because many of these services have historically been supported by HIV-focused donors like PEPFAR and the Global Fund, many of the services have historically prioritized populations who are injecting opioids, many of whom are men. However, women represent an increasing number of people initiating opioid agonist treatment in South Africa. And in the context of HIV service delivery, a growing number of these women identify as female sex workers. Unfortunately, female sex workers remain underserved and undersupported by existing methadone services. Frequently, HIV and health-related services for female sex workers are delivered in parallel but siloed fashion to opioid agonist treatment services, which oftentimes are housed within other services for people who are injecting drugs, many of whom are men. These spaces, therefore, can be male-dominated and may be considered hostile, unwelcoming spaces to some female sex workers. I hope this won't be terribly provocative of me to say, given the realities of opioid agonist treatment services in South Africa, that methadone availability isn't the primary problem, but rather access is. So given these realities, our research sought to understand how we can leverage and capitalize on the successes of methadone programs in South Africa while adapting or tailoring specific components so that they can better meet the needs of female sex workers living with HIV. This brings us to the present study, which was implemented in 2 districts in South Africa, eThekwini and eShlanzeni. For those needing a quick primer of South African geography, eThekwini is an urban district in eastern South Africa, located within KwaZulu-Natal province, which includes the city of Durban and the surrounding metropolitan community. eShlanzeni, by comparison, is located in northeastern South Africa, near the border of Mozambique and Eswatini. If you are familiar with this area and have been to Kruger National Park, you've likely flown into the municipal airport in this district, where you can gain an appreciation for both the peri-urban as well as rural communities that are located within this district. We purposefully selected these 2 districts to do our research. One, because TBHIV Care, our amazing partner in this work, has services embedded in these 2 geographies, but also the rurality and geographic differences have tremendous implications on the illicit drug markets in these areas, how people are using drugs, and the types of services that are available. So we conducted semi-structured in-depth interviews with 16 female sex workers living with HIV who self-reported current opioid use or current methadone use, and 10 service providers of both services to female sex workers and people who inject drugs. And these types of providers include clinicians, nurses, peer navigators, case managers, social workers, really anyone that's part of this service delivery architecture. So we used a rigorous but rapid qualitative analysis approach to interrogate dimensions of methadone implementation and necessary adaptations to better meet the needs of female sex workers. We began by exploring barriers and facilitators of methadone service delivery, which were organized around the Consolidated Framework for Implementation Research. We then sought to characterize pathways to methadone induction and continuation among female sex workers using the trans-theoretical model of health behavior change, which likely needs no introduction to anyone in this audience. And lastly, to explore recommended adaptations to methadone service provision for female sex workers, we nested specific features of methadone service delivery across the 4 domains listed here that are part of the ADAPTOME framework, which is a framework that helps to organize specific components of evidence-based practices that require adaptations when implementing in new populations or new settings. So rather than exhaustively summarizing all of these results, I'd like to share one of our participants' experiences with methadone services, which I think very nicely captures some of the implementation barriers for this population. So I'd like to introduce you to Tulile. This is a pseudonym that we've given her. She is a 27-year-old female sex worker from Eshlanzeni who has been using heroin for about 6 years. And when we met Tulile, she had recently started methadone and explained that she was motivated to start because it was impacting her day-to-day capacity to work and adhere to her HIV treatment. And so she described the life-changing effects of methadone, but shared that because she had to visit the clinic every day for her methadone dose, which was rather far from her home, she would on occasion miss doses and experience debilitating opioid withdrawal symptoms that impacted every aspect of her life. And one of the methadone providers at the clinic where Tulile received her methadone explained that for many sex workers, their occupational schedules competed with the operating hours of the clinic, and explained that even when a mobile van was configured to deliver methadone services on wheels, some sex workers avoided these services because they would not want others to see them accessing these mobile services and be known as women who were using or injecting opioids. And so I think Tulile's experiences with methadone services reveal many of the barriers we identified to methadone service delivery for female sex workers, which we've organized along the social ecology that you see displayed in the concentric circles on the top right of the screen. And so at the individual level, really the onerous nature of daily directly observed methadone dispensing posed challenges to female sex workers whose competing work schedules constrained their capacity to routinely visit methadone dispensing sites in person. Similarly, sex workers were particularly concerned about their clients, their peers, and their families seeing them access methadone services, whether in person or whether delivered via mobile. And some sex workers also described concerns about the anticipated or experienced somatic consequences of methadone, specifically experiencing withdrawal symptoms that would interfere with their work and not having access to a drug that may help them attenuate the lingering or lasting effects of stimulants like meth or crack, which were oftentimes used as part of their everyday survival in this context. And at the organizational or institutional level, some clinics really only had capacity to deliver methadone via static or brick and mortar clinics. And so oftentimes this was because there were insufficient resources or personnel for mobile methadone delivery. Some other clinics were set up in such ways that services tailored to female sex workers were delivered via drop-in centers that were scattered or located in different spaces than services for methadone, which oftentimes were housed within PWID programs that were predominantly serving folks who inject drugs and a lot of men. And lastly, I think it goes without saying that the overburdened peer and clinical workforces who are doing a lot with very little make it very difficult for in a single encounter with a sex worker, whether at the drop-in center or whether via mobile, that they were able to really meet every one of the client's needs in a single encounter. And lastly, at the policy and systems level, in some cases, donor funding requirements made it such that only folks who were injecting opioids really had access to methadone. And this was largely an artifact of HIV, these HIV-focused donors that really had used these requirements, in essence, to really limit who would be receiving methadone due to resource constraints. Similarly, the regulatory restrictions around what kind of providers are able to prescribe methadone. There is an amazing nursing workforce in South Africa, many of whom can dispense methadone, but are not able to directly prescribe the methadone. And this creates a lot of complications, both in terms of service delivery as well as liability. So if there is a methadone attributed overdose, for example, the nurses really would be held liable, not necessarily the prescriber. And so these findings really helped us identify features of methadone services that could be adapted to better meet the needs of female sex workers. And so at the service setting level, expanded availability and geography of mobile services, coupled with methadone programming that incorporates sex worker peers, could improve reach to sex workers. These services could also include wraparound services that are more tailored to sex workers' needs. So, for example, hygiene packs or lipstick and cosmetic dispensing, and also co-locating methadone delivery within ART or antiretroviral therapy services to sex workers, as well as sexual and reproductive health services, were perceived as expanding the reach of services so they'd meet the needs of sex workers. Furthermore, because sex workers explained that these services were at times incompatible with their needs and priorities, extending clinical operating hours or availing gender-specific trauma-informed services could render methadone provisions more amenable to female sex workers. And finally, availing earlier access to take-home or mobile dosing would mean that methadone continuation and retention in this population may be higher because sex workers would have access more quickly to more flexible dosing schedules. And so these are not monolithic populations. These are heterogeneous populations with diverse needs. And so being able to avail services that are agile, person-centered, and tailored to the individual needs of clients is critical, but we need more resources and support to do this work. And so as the old saying goes, there is no choice without option, and there is no option but choice. And I think that very much applies here. I owe a debt of gratitude to the incredible staff and collaborators at TB Care who make the impossible possible. I also acknowledge the contributions of all the investigators and collaborators at Johns Hopkins University, Columbia University, and UC San Diego. Thank you so much for your time.